Hello, everyone. Thank you for joining us for our final webinar for the year. We've had a wonderful year of monthly sleep seminar series, but they're really a webinar, they're online. And we really appreciate you coming live. And of course, you can, if you're watching this later, I really appreciate you watching this to catch up on such wonderful information about improving sleep in school-age children. Before I introduce our wonderful guests tonight, I'll introduce myself. My name is Moira Junger. I'm the proud CEO of the Sleep Health Foundation. We're a not-for-profit organisation aimed directly at the consumer, to the general community, and really want to improve people's lives by better sleep. So that's schools, organisations, the general public, really. So we're really, really happy that you've joined us tonight. Before I go further, I'd like to also do acknowledgement of country. I'm on Wurundjeri land, the land of the people of the Kulin Nation here in Melbourne, and so are our guests. And wherever you are, I pay respect to the traditional owners and their elders, past and present. And Sleep Health Foundation particularly like to pay our respects to the First Nations people's understanding of health. And I really draw great inspiration that they see health as a community thing. It's a collective thing. It's not an individual model that we often have in our in more Western society. And you're only as healthy as your community and as your mob. So we take great inspiration from that. So I'm going to just stop sharing the screen so you can see us a little bit more. And I'm going to introduce our guests. And we first have, in no particular order, we have Professor Harriet Hiscock. And Harriet is a consultant paediatrician and fellow of the Australian Academy of Health and Medical Sciences. And she's Associate Director of Research at the Centre for Community Child Health, Director of the Royal Children's Hospital Health Services Research Unit, and Group Leader of Health Services at the Murdoch Children's Research Institute. So really, really warm welcome to you, Harriet. And we also have Dr. Mandie Griffiths, and Mandie is a paediatric respiratory and sleep physician working actively in both sleep disorders medicine as well as respiratory medicine. And Mandie sees patients with all kinds of sleep disorders, including obstructive sleep apnea, narcolepsy, and the hypersomnias, behavioural sleep disorders, periodic limb movement disorder, and children requiring respiratory support during sleep. So I could go on, but I think I'll leave it there, for the bios are much longer than that. And the way it'll work tonight is that I'm going to fire a range of questions to both Mandie and Harriet, and then I'll step back really and let them talk amongst themselves, perhaps with a more medical sort of approach and the more behavioural approach from Harriet, and just decades of insight around children's sleep. We'll start with more primary school age children, and of course, school age children is adolescents and teens as well. Even in primary school, by the time they're in grade 6, a lot of them are adolescents. So we're sort of covering off the younger children as well as the teenage years. So I think what I'll do is ask our guests first of all, so Harriet and Mandie, and then I'll step back, is I want to ask you what about the most common sleep disorders, the most common sleep issues actually that you see in primary school age children. Like, why do they occur and what can be done about them? So sort of a big, broad question, just to throw it to you two.
Well, thanks, Maura. Well, I might start off, as you said, I'm probably more knowledgeable about some of the behavioural things. Mandie's great at that, plus all the really clinical medical things. So in terms of the behavioural things, I like to sort of categorise it as kids having problems getting off to sleep, kids having problems staying asleep, and then problems maybe waking up too early in the morning, which is not a problem in the teenage years, but it can still be in primary school. And the really common problems we see getting to sleep is what we call a sleep onset association disorder. So that's where a kid associates with something or someone to get to sleep. Often it's mum or dad. If mum and dad are there, they can get to sleep fine, but if they're out of the room or out of sight, they can really struggle to get to sleep. Another common problem we see, which is really emerges around toddler age, but can sometimes still be there in primary school age, is limit setting disorder. And these are the kids who come in and out of the bedroom at the start of the night. I want to drink. I want to tell you something. I want to go to the toilet. What we call curtain calls. And it can be quite hard for parents to set limits around that. And then I think increasingly we're seeing kids struggling to get to sleep because of they're worried about stuff, so they're anxious, and they might be lying in bed worrying about something that's gone on during the day at school, learning or homework or interactions with peers and bullying, or something that's going on at home. Well, certainly in the kids I see, increasingly they're worrying about some of the really big issues in the world, like climate change, for example. So I guess they're the common things I see getting off to sleep. Mandie, I wonder what you would see. Anything different to that?
Well, I definitely see all of those things. And then you start to see that other group of kids who are having those wake ups after an hour or an hour and a half of sleep. And they might be either getting up and walking around, but they're still asleep, so sleepwalking. Or they might be, the younger group might be a little bit confused and crying and thrashing about and not able to respond to parents. Sort of more in a confusional type state. We call them confusional arousals. And then the older kids may be more into a night terror sort of a setup where they have a shrill scream and terrified. They're awake for, say, 5 to 10 minutes. Well, they're not awake, but they're up screaming and confused, and they're difficult to console, and then they'll just go back to sleep. Sometimes this will happen after another hour or hour and a half on the same night. Sometimes this is happening for some families every night, or other times it may just be once sort of a month or at different times of the year when they get particularly overtired, because sleep deprivation is certainly one of the factors that can propel these parasomnias. So that's another thing that from a behavioural point of view that we would see, well, I would see quite a lot of. And there's lots of things you can do there to help manage that. Perhaps getting more into some of the medical things. I see kids who have snoring and obstructive sleep apnea almost every day of the week. So the things for parents to look out for there are sort of habitual snoring. So snoring which is significant, loud, for long periods of time, heard on at least 3 days a week over, many weeks. Other symptoms may be really restless sleep or pauses in breathing followed by gasping noises, mouth breathing. That might be a trigger to, these things might be a trigger to waking up in the night. If parents are seeing those sorts of things, it's really important that they go along to their doctor and have an assessment, and they may need referral depending on the age and stage and symptoms of this. And, it may be as simple as the GP prescribing something like a saline spray or a nasal steroid spray, or it may be more significant. It may need some ENT input, or it may need to come along to one of us, like a sleep physician, for further assessment.
So, Mandie, do you ever get parents to video their kids sleeping at night? Or, often parents will come in to me, and I find it really helpful, and I particularly ask them to pull up the pajama top so we can look at if kids are obstructing or not. What does that look like for parents?
Some parents will come along to the first appointment with a video, and I find it really helpful, and it's actually got a really good positive predictive value, a video for obstructive sleep apnea, which means that if you see a really good evidence of obstructive sleep apnea, then it's likely that the child will have that. So I find that really helpful. It's something easy for people to do these days with their phone. And, if a child's snoring and parents are unsure whether it's, a bit of a benign snore or a more significant snore and sleep apnea related, then that can be a really useful tool for them to bring along. So yeah, I definitely see that. I also see parents just bringing along audios, which is equally helpful. Sometimes they don't want to put a light on and wake their child at night in the dark. So, but yeah, all of those things are good. And I guess,
I was going to say, Manny, I think one of the things we also miss sometimes, and parents may not always know about, is restless leg syndrome. I wonder if you want to talk about how that might present in kids.
Yeah, so restless leg syndrome is more an awake condition where adults or children can feel a very uncomfortable feeling in their legs, which often is more pronounced towards the end of the day as they get more tired. And they have a strong desire to move their legs to make that feel better. And there's a nighttime version, which we call periodic limb movement disorder, which may or may not be associated with restless legs in one individual. So that is, you can either have one or the other, or you can have both. But this is something which can trigger awakenings from sleep. And so sometimes when patients come along and the description is that the child is waking frequently throughout the night, I wonder whether or not this might be a factor in their waking, and start to inquire a little bit about iron in the diet, because we know that iron deficiency and restless legs and periodic limb movement disorder go along together. So, for example, vegetarian diets can be troublesome for maintaining a decent iron balance. That might be an indicator that that may need to be looked at. And, of course, the good old sleep study, which is the overnight investigation to rule out or rule in obstructive sleep apnea, also will tell us about periodic limb movement disorder with the limb leads. So we make that diagnosis from a sleep study.
Yeah. And sorry, Maura, I was going to jump in. I think one of the things too is to really understand, sleep problems, like what Mandie and I have been talking about. You sort of need to understand normal sleep. And there's a lot of information on the Sleep Health Foundation about that on the website. But certainly what we all do is we all start off the night awake, obviously, and then we take quite a bit of time, maybe up to 20 minutes to fall into deep sleep. So sometimes I'll have parents come to me and say, oh, I just won't fall asleep. And you say, well, how long is your child taking to fall asleep? And they're saying, oh, it's 20 minutes or 15 minutes. And that's totally normal. And, as an adult, we don't, well, you're lucky if you do, but typically we don't just put our head on the pillow and go straight to sleep, although my partner does. I'm very envious of them. But often it takes a bit of time. And then we go into our deep sleep. And in the first few hours of the night, that we might stay there for, a prolonged period. And then we come up into light sleep, go back into deep sleep, up into light sleep, back into deep sleep. And we keep cycling like that throughout the night until we wake up in the morning. And those sleep cycles in us as adults are 90 minutes, but they're shorter in children. And that means that as kids come up into light sleep, they can move around, they can grizzle, they can groan. And another thing parents will often say to me is, my kids are really restless sleeper, particularly if their child is sleeping alongside them. But sometimes that's just because relative to adults, they're just having these periods of being in their light sleep and moving a lot more. And I guess the other really important thing is that the way your child goes to sleep at the start of the night is the way that they will want to go back to sleep when they naturally wake up overnight. So if the last thing they can remember is falling asleep on the couch, or with mum or dad right next to them, patting them, or shushing them, or whatever it might be, when they naturally wake up from their light sleep overnight, they might look around and go, where am I? Why aren't I on the couch? Where's mum? Where's dad? They might call out, they might come out of their room. And that's the sleep association that I was talking about before. So I think just knowing that cycles of deep and light sleep are normal, knowing it's normal to wake up overnight, but the problems we see is when a kid hasn't learned to put themselves back to sleep overnight.
And just to add to that a little bit further, we see that there's a difference between the first part of the night and the second part of the night in terms of that sleep architecture, which is the different stages of sleep. So in the first part of the night, there's more deep sleep. So there's cycles in and out of deep sleep and REM sleep where there's a lot of dreaming. But in the later part of the night, there's less of that very deep sleep. And then there's more sort of in between REM and what we call stage 2 non-REM cycling. So that you get a lot more dreaming in the second part of the night, but you get a lot more susceptibility to waking as well. And also that might be a time where you see more nightmares because there's more REM sleep. So those things are important to understand when you're listening to a story about what's going wrong with sleep and how the interruptions might relate to those sleep stages. And the other thing I was going to just suggest is that we think about what it takes to actually get a good night's sleep. And in that way, I was thinking you need adequate environment, adequate duration of sleep, and adequate quality of sleep. So you need enough, you need to be in the right place for it, and you need it to be of the right quality in order to wake up in the morning and feel refreshed. And if any of those things aren't quite right, then that can mean that sleep is not as refreshing as it should be. And it's sort of sometimes our job to pinpoint exactly why that is, but those are the sort of factors that go into feeling good and feeling refreshed from your sleep in the morning.
And so, Mandie, what's the right environment and what's the wrong environment for sleep for kids?
So, well, it's important to make sure that children have their own space. Now, that doesn't have to be their own room, of course, because that may not be possible, but to have their own space where they can feel safe enough to relax and to relax into sleep. The pre-sleep environment is also extremely important. So in that sort of hour or two before bed, it's important to have a consistent routine. And some of the things that are good for sleep promotion are to detach from electronic devices in the half to 1 hour before going to bed, and try and have a bit of time outside the bedroom at that point in time. And I don't mean outside the house, I more mean not in the bedroom, sort of in the bed doing things on the computer or doing any homework or anything like that. It's important to sort of keep the bed for sleep, and it's good to be outside of the bedroom environment if there's any issues falling off to sleep, so that children don't kind of look at the bed and get a little fearful of what's going to happen when they get in that night and try and fall asleep. So I call it an hour of quiet time, and I set kids up in a living room with some books and quiet activities, and have parents coming and going while they're getting the dinner cleaned up and those sorts of things, so that there's just that sort of period of winding down and getting ready and getting drowsy and getting ready to go into bed.
Yeah, and I think that's great advice. And I think one of the big issues, that most people on the call probably know about is that the blue light from the screens blocks melatonin, which is our natural, brain hormone that helps us get to sleep. But it's also the content of what they might be doing on the screen that could be quite arousing. And there are some studies that show, that playing certain games that are really exciting and engaging just before sleep obviously doesn't help a kid get to sleep. But I think it's really hard for parents because there are lots of apps now out there about, relaxation and mindfulness, and they're all on a phone. Maura, Mandie, how do we navigate that? And this is happening in primary school.
Yeah, I was going to ask you about that around because it would probably, the more nuanced message at the moment from the Sleep Health Foundation, knowing that everyone's on devices, really, even primary school age kids, have devices and often in their room, and really around limits setting and whether there's any room for some activity might be short, just if it's only short, that it might be relaxing, like that, where is the role for, especially if there's no blue light or there's not, they've got night mode on it. And if it's to say a relaxation thing or listening to a podcast, listening to a story. So is it all, in your mind, is it all electronic devices, or more the engagement with it and the content and the length of time and whether there's light? Can I draw you out on those things with I think they're really helpful for the audience of parents around a complete ban or a nuanced approach.
Yeah, I think that it's obviously a bit difficult to be too black and white in this area. And so you need to take the specific situation into account. Obviously, if you're treating a patient and they may be a particularly sensitive patient who needs less of that in the evening than the next patient who comes along. But in general, there are some really great things on those devices that are useful for winding down. And so there might be some kids who actually use that Calm app in their quiet time to actually start to become drowsy, whereas others are too sensitive and not able to do it. So it's really about tailoring the approach to the individual. There's always the nuances in the history. Take a lot of time making sure that I know exactly what's going on in that household before I start recommending things. But I think being black and white about these things is a little bit silly.
Yeah, I agree, Mandie. And I think the other big clue is, if your child's using something at the start of the night and they're getting off to sleep, okay, it's just not a problem. But if it's stopping them getting to sleep, and by that I mean taking 30 minutes or longer to get to sleep, or if they're waking up overnight and they're reaching for that device again to get back to sleep, then that's a sleep association, and that that
It's not
goes
help.
into that,
Yeah.
sleep association disorder again. Yeah.
Go back to a question. I've got a question around sleep. We're talking about sleep apnea before, Mandie,
Yeah.
and like the loud snoring and all those sorts of things, and whether they at night what's happening and videoing it. What about the clues around like the child that might be sleepy during the day, sleepy in class, maybe not reaching their milestones? Can I draw you out as, and maybe, I mean, is it the snoring that's the real thing rather than the daytime manifest?
Oh no, it's all of the above, Moira, as you know. So there's the symptoms that go through the night, which, that's easy if you're standing there by the bedside and watching. Not that anyone wants to do that all night. We don't. But, when you get opportunity to go in and check the kids, then those are the things to look for. But it may be that opportunity is not there that often, and that, the first thing parents notice is actually it's getting harder and harder to get their child up in the morning. They're more groggy, they want to stay in bed longer, they may be really grumpy and finding it difficult to wake up. And then during the day, perhaps there are reports from the teacher that they're looking like they're not concentrating as well as previously, or behaviour is an issue where it wasn't previously. So those are certainly associations with obstructive sleep apnea or any cause of sleep disruption, really. Daytime symptoms of fatigue or hyperactivity can be quite common in primary school age children, to become more hyperactive when they're tired to keep themselves awake. So those symptoms are most definitely important in the big picture of what could be going on during the night. But if you have snoring in association with these kind of daytime symptoms, then you're looking down the pathway towards considering obstructive sleep apnea.
Yeah. And then I suppose one more question before I get on to what to do about it, like, the treatments, I guess, for what the available treatments are. And then we'll talk about teens and then a few other things. There's so much to talk about. But I was thinking about the night terrors. A common thing that I get asked, and I'm not a pediatric expert, but the whole night terrors as opposed to nightmares, like sort of, and that first half of the night and the second half of the night.
Yeah.
Tell the audience about that.
So what happens with night terrors and sleepwalking, which are the classic parasomnias, is that they occur at the end of your block of stage 3 for sleep. It's called all stage 3 now, the deep sleep block, and just at the point where you would otherwise go out into your REM sleep, but
which is your light sleep,
which is your brain awake, but dreaming sleep. And instead, there's a partial arousal where the child gets up or screams and sort of is stuck in between that deep sleep and an awake state. So those things are quite easy to pick on the story because they occur between 1 and 1.5 hours after going to sleep at night. And it's always the same timing. Parents come in and say, like, I could set the clock and then they'll be up. There's often a family history of that. There's often a history of something else causing sleep disruption because they're usually triggered when the kids are getting a bit overtired for some other reason. So either their regular bedtime is too late, or they've got snoring and obstructive sleep apnea, reducing their sleep quality, and these things occur at that time, as opposed to nightmares, which are more likely to occur usually out of REM sleep. And so they can occur in the early hours of the morning when there's cycles in and out of REM and stage 2 more commonly than deep sleep. So it might be 4 a.m. waking with, crying and upset and describing dreams. But they usually would wake up out of a nightmare, whereas in those other conditions, they can be asleep. Well, they are asleep at the time when they're walking and when they're having a night terror. They can wake out of those as well, but we recommend not to wake children out of those because sleep deprivation is actually fueling them along. So more waking out of those episodes is more sleep deprivation.
Yeah, I agree. And I think the other really useful thing for parents is if they hear their kid waking and upset, the first thing you do is rush into the bedroom. If they pick up their child, if their child pushes them away, it's usually a night terror. But if the child's cuddling into them, as Mandie said, it's because they're actually awake and they're aware, and they'll come for a cuddle. And a child will remember a nightmare in the morning, but a night terror, unless you've woken them up completely, which is why we don't want you going in and doing that, if they're just having that night terror, they're actually not awake. Their body's awake, but their mind isn't, and they won't remember it in the morning. So there's some
And
other ways parents can tell. Yeah.
They can be really activated during those episodes, and it can be quite frightening for parents. In fact, many parents have described them to me as if their child is possessed. But it's important to know that their children are not in pain or distress during those events, and that they are part of sleep, and try not to panic too much and just get them back into their sleep in bed.
So in general, I suppose rounding up the primary school age sort of sleep issues, do you anything more to add around like what's the best approach, I guess, or treatments, either medical or what parents can do themselves?
Depends on what the problem is.
Yeah.
So I can cover just briefly the behavioural things. So when we talk about that sleep onset association, that's when the kid can't fall asleep unless usually it's someone or something is there, so mum or dad. So there's a couple of options parents can have, because if you can teach your kid to fall asleep at the start of the night, then they'll start to learn to put themselves back to sleep when they naturally wake up overnight. And there's really two options. One is, the checking method, or also called controlled comforting, or the technical term graduated extinction, which is a pretty awful term. But that's when, as Mandie said before, you have a good bedtime routine, you tuck your child into bed, give them a kiss, I love you, good night, it's time to go to sleep, and then you leave the bedroom. And then you listen out. And if they're, protesting or crying, you go in after a couple of minutes and you say the same thing, I love you very much, but it's time to go to sleep, kiss, good night, and then you leave the bedroom. And sometimes parents just leave for a sort of set time interval, but other times parents increase that time interval that they're outside the bedroom. And the aim is that you'll come back and your child has fallen asleep without the need for you to be there. And, if it's working well, it might take between 3 and 5 nights to work. And then if they're waking up overnight, parents can do the same thing. Or if they're feeling really exhausted, they might say, for the first week, I'm just going to focus on the start of the night and getting that right. And if my kid wakes up overnight, I'll let them come into bed, as they usually do. And in week 2, I'll do that again. But for some parents, they go, I just couldn't do that because my kid seems really stressed or anxious when I leave. And then we talk about the camping out method. That's where you put a camp bed or a chair right next to the kid's bed. And the first few nights you might hold their hand or pat them off to sleep. The next few nights you might just sit there and talk to them, but not actually touch them. And then you slowly move your camp bed or chair outside the bedroom. And that might take anywhere from 7 to 14 nights or even longer. And that's just giving the child sort of that confidence to fall asleep by themselves, but in a more gentle, graduated way. So that's the sleep onset association. The bedtime coming in and out, the bedtime calls, the limit setting. We do a bedtime pass method where we get parents to make a little pass out for their kid, and they're allowed to use that pass out once at the start of the night. So it might be for a drink or to tell their parents something, and then they hand that pass out over to their parents, and that's it. They stay in their bedroom for the rest of the night. And we pair that with a reward system in the morning as well. And we can talk about the other one more if there's more questions later on, but anxiety is really common. I'm seeing more and more of that in my practice. And so I often use a visual imagery relaxation approach to help kids stop thinking about what's been going on during the day that's worrying them. They might take themselves off to a beach in their mind and sort of do sequential muscle, tightening and relaxing from the toes, working all the way up. And there's some great resources online about how to do that. And another thing I tell parents not to do, because some parents do it, is they tuck their kid into the bed and they go, and tell me, how was your day? And then all the worries come out just before bedtime. So don't do that. Do it in the afternoon, well separated from the bedtime.
Right. And there's more, we can talk about where to find these resources to learn how to do this and remind yourself of that. Mandie, what about, there's sort of the things you talked about, the medical stuff. Obviously there's treatments, but do they obviously have to have a medical specialist for those things?
Yeah. So thinking about kind of kids between the age of, say, 2 and 5, if they've got a significant history of obstructive sleep apnea, they may end up at an ENT specialist who confirms large tonsils and adenoids and may go ahead with surgery. And if that's the case, then in that setting, that's a reasonable thing to do. if there's a question in an ENT surgeon's mind about whether it is or isn't obstructive sleep apnea, they'd often refer to us for a sleep study. And then we get the gold standard test. We get the answer at the end of the night after collecting quite a lot of information from lots of electrodes and sensors. We actually are able to say, is this obstructive sleep apnea? Is this primary snoring, we call it, if there's no obstruction? And if there is obstructive sleep apnea, is this mild, moderate, or severe? And what treatment do we recommend? So if it's moderately severe or very severe, we would still, in the first instance, recommend in typically developing children ENT surgery. It gets much more confusing when you think about the complex group of children that I often find myself seeing at the Children's Hospital. But in typically developing children, that's the first line of therapy for moderately severe obstructive sleep apnea or severe OSA. In the milder groups, though, and it's all a spectrum really, from primary snoring at one end right through to severe obstructive sleep apnea. And in fact, children can move along the spectrum from one end to the other, according to various different things, such as viral infections, which make tonsils and adenoids larger, that sort of thing. But at the milder end of things, we've got some medical therapies available, and we're just working through some research. Actually, Harriet and I are involved in together, where we're trying to ascertain whether nasal saline spray is as good as nasal steroid sprays for this particular condition. And some preliminary evidence came out around Christmas time last year from our work that it could be the case, but we're doing a follow-up study at the moment to try and clear that up. But those are simple treatments that can be quite helpful to clear stuffy noses, reduce the swelling of the inside of the nose, which could be a problem in hay fever, for example, or other allergies, and also to reduce the size of the adenoids, therefore reducing the reason for obstruction. So those things are quite helpful.
Yeah, so Mandie, it takes ages to get in to see someone like you or an ENT surgeon. So do you recommend families trying this anyway, like going to their GP, either trying the nasal spray, which is over the counter, the saline spray, or the steroid spray, is also over the counter in many cases, and it's usually for 6 weeks, I think we recommend. Do you say families should just try that anyway while they're waiting?
Yeah, there's absolutely no harm in trying those things. Although, I guess I should say no harm at all. With nasal steroid sprays, you can get nasty blood noses, and it's not recommended to continue if that's the case. But it's good to have a GP consultation first, because sometimes there's indicators that things are much more complicated or much more severe than perhaps was previously known, and there may be a referral indicated at the first presentation. I think GPs are getting better and better at prescribing these things in the right circumstances, or referring on if they don't know. So yes, 6 to 8 weeks on either a saline spray or a Nasonex type spray, nasal steroid type spray, would be a great start, even if a referral's in the pipelines, as you say, can take quite some months to get in.
Yeah, and just to say, a saline spray is a saltwater spray, just for the
Yeah. That's fantastic. Now I'm going to just quickly ask a question from Catherine on the line, even though we have Q&A at the end. But I just think while we're talking about sleep associations, and Catherine's asked, will this be considered a sleep association? My child has rituals he has to complete before trying to fall asleep, checking all doors are locked, even if I've checked, has to say a specific dialogue and have each family member come in and say goodnight. He generally doesn't get up during the night anymore. Should I accept the rituals or should I seek treatment?
That's a great question. So I would say, does he do these rituals at any other time? Would be important to know. Is he doing it, for example, before going to school or going out? And is it interfering with the function of his life? So some kids can just have these rituals and there's nothing else associated with it. Sometimes, but usually it would not just be around sleep. It might be an indication that other things might be going on, there might be some more of the flavour of an obsessive compulsive disorder. But that's usually when kids or adults have things in their mind they're worried about, and they do the rituals to get rid of those thoughts. So it's actually understanding a bit from him why he's doing the rituals. And those kids it tends to happen during the day, you know, before school, at school, etc. So I guess I wouldn't, if it's just before bedtime and he's sleeping through the night, I wouldn't challenge it too much. If you're finding, though, it's stopping you functioning as a family because this is a 1 hour or 2 hour ritual, you might have chats to him about how do we start to reduce this and just bring it into a little bit more of a manageable, you know, set of behaviors he's doing. So I think it's really, is it happening in any other times of the day, and is it affecting the functioning for him, would be really important things to consider. And if it is, it's definitely worth going to see your GP about a chat to get that checked out a bit more.
That's great. So I want to get on to sort of teens, pre-teen, like sort of this slightly older kids going to adolescence, pre-adolescence. What are the main sleep issues? Why do they occur? What can be done about it? So big questions, I know, but over to you to I'll keep an eye on that. I'll just see if this is a question that yes, that's great. So yeah, over to you for the teen kind of overview and what can be done.
So certainly this is a stage where we see this natural shift in the sleep phase, the biological clock of kids, and this wanting to go to bed late and wanting to get up late. And this is around the world. And it's interesting, if you go to some schools in America, they've accommodated this in high school would start at 10 a.m. in the morning. But we haven't got that in Australia, unfortunately. So it's a very natural shift to want to go to bed late, get up late and start the day. So you find you're trying to get in your preteen or your teenager out of bed, and there's a lot of often conflict between parents and their kids at this time. And then it's compounded by social media and wanting to stay online, wanting to stay on screens. If the kids have their phones in the bedroom and it's not on do not disturb, they're pinging away, you know, and that's really bad for their sleep and sleep quality that, you know, Mandie was talking about before. So I think that's the main shift. Mandie, would you say if there's anything else?
Yeah, it's just a time, I guess, where especially in the years post-COVID and around COVID, that it's important to look out for other things emerging. 1 in 4 teens are anxious now, and you know, there's a lot more anxiety and depression, and that can affect sleep.
Yeah.
And so just to try and be aware and try and sift between, you know, is this normal teenage behavior, or is this actually mood disorder evolving? If there's a difficulty with sleep, because it can be part and parcel of anxiety or depression to not be able to get to sleep. So I guess distinguishing therefore between delayed sleep phase and the sort of, you know, not being able to fall asleep at an earlier time and wanting to go to sleep later, but easily falling asleep at a later time and then sleeping a usual night's worth through to whenever they're either woken or naturally wake up in the morning, which would be more a delayed sleep phase picture, versus a not going to bed till later because it's hard to get to sleep, and then perhaps waking in the night and even sometimes early morning waking, which is more of an insomnia picture. And that's more common now than it was even when I started in this field, and a lot more common since the pandemic, unfortunately.
Yeah.
So I guess that's important to start thinking about. In fact, I think the statistics now are more teenagers with insomnia than delayed sleep phase.
And it's really hard with the mood disorders, I agree, because the other thing is depression and anxiety in teenagers can present as irritability. And we often just write that off as, oh, they're just being a teenager, it's the hormones, it's really annoying. But again, it's looking at the whole picture, as sort of Mandie's saying, and is your child no longer enjoying things they used to enjoy? Are they no longer going out with their mates? Have their eating habits changed? Are they eating more, or are they eating less? Are you starting to hear the negative self-talk, you know, about self-esteem, or, you know, I'm dumb, I'm stupid, I'm hopeless? So all those other sort of clues that might be happening that can start to help you think about, is this just normal, sleep shift of a teenager, a phase shift, or is it something to do with their mood as well? In which case that's certainly an indication of to go and see a GP and start that conversation about, you know, trying to get into a psychologist or see the school counsellor and get some support.
And I guess the other thing to say is that teenagers are just not getting enough sleep across the board. And so we know that teenagers actually need 8 to 10 hours, and they probably need at least 9 hours on recent work. But during the week, during the school week, because of their delay in sleep phase and, you know, other things, they're getting to bed late and still getting up for school early. So they're often getting 6-7 hours sleep on all the school nights. So when it comes to the weekend, they do have a need to catch up. And so it's hard for teenagers who are playing sport every Saturday and sometimes Sunday as well, because they don't get that opportunity to catch up. But we do see this sort of pattern where teenagers will have, you know, shorter sleeps during the week and then several longer sleeps on the weekend. But what that does then is make it harder to get to sleep on Sunday night for Monday. So it's a very tricky time for teenagers.
Yeah, and so it sounds like it's this phase delay that happens, like a natural delay in when your melatonin's coming out and your whole sleepiness, propensity for sleepiness. It's also a time of greater independence, of course, like, you know, and it's harder to control what they're doing, like in terms of not control, you know, be across how much screen use they have and all that sort of stuff. So there'll be questions. There's one already about blue light glasses, and there'll be questions about melatonin. So perhaps we should talk about both those things around how, advice or encouragement around how, if there is a delay, there's things we can do about it with, you know, with either melatonin or light in the morning or blue light glasses. Can you tell us your take or, you know, your view on those sorts of things around managing the circadian rhythm?
Well,
I suppose we can just answer this question in terms of the question from
you go first, Mandie.
from Rebecca, like, do blue light glasses work?
Yeah. We thought they did. Well, so in the evening, we want to get rid of the blue light, and in the morning, encourage it. So we thought they did, but recently there's actually been evidence that it's not such a huge thing. But certainly keeping a regular time of going to bed and exposing to light in the morning resets melatonin for the next night. So trying to not let that slip and sleep is important. Unless it's a problem, we wouldn't recommend people going out there looking for supplemental melatonin, because the jury's still out on some longer term work, et cetera, where it's needed. Then we will use that in our clinical practice. And it's particularly useful in children with autism and other neurodevelopmental disorders where there's evidence that they have abnormal melatonin, either secretion and or action. It either is, you know, it doesn't peak at the same time or it's lower in amount. So there's good research evidence to back up the use of melatonin as a supplement in those children who are having quite a lot of difficulties with sleep. But it's not something to reach out for at the first grasp. It's much more important to look at sort of timing with light. Would you agree with that, Harriet?
100%, Mandie. And one of the things I tell my teenagers is if they're happy with this, when you go to bed, leave your blind up or open your shutters. And it's easier in summertime because the sun's coming up now, and that will naturally start to switch off their melatonin and help them just wake up a little bit better than maybe the alarm or the parent trying to shake them to get them up, to get them ready to go to school. So the sun is your friend, much harder in wintertime, I acknowledge. Yeah.
And blue light glasses, I mean, I would imagine, I've heard lots of people speaking around, you know, whether you need lamps, glasses, all sorts of stuff. Do you think people are better off perhaps just turning off their screens earlier or having the screen on night mode rather than having to have, you know, blocking glasses? Or I suppose there's kids doing late homework that need to have what's your take on blocking glasses?
I don't know. I mean, I've sort of used them a little bit over the years, but I guess it depends if it's a problem or not. But I haven't tended to use them so much in recent times. I think what's really helpful is to actually go around the house and start dimming all the lights in the hour before bed and giving the signals that way. I think that works really well. And then, as Harriet said, having an opposite sort of reaction in the morning, like having the blinds up as the sun comes up, or just making sure that the adolescent gets up at the same time and goes outside into the light, especially this time of year. You know, you can sit out on the back deck and have breakfast or, you know, do it like sit inside beside a window, that sort of thing. I think that's probably, you know, it's an easier thing to facilitate in clinical practice than actually teeing up the glasses. You can get them from like the local Sleep Easy or CPAP Australia. Those sort of places do have glasses, and you could pop in and get them, and if that's what people want to use, that's great. Other people are keen to get the visors, like the retimer visors, or buy the light box, depending on if that's something they're able to do. And certainly if we're treating significant circadian rhythm disorders in our practice, we can use those sort of props. But on the regular sort of teenage type issues, it's easier to just use what you've got naturally.
Yeah, and cheaper.
Yeah,
a lot cheaper.
Simone's put a comment really around, how can we get the world to think early dinners, parties, etc. are cool? To have a cultural shift at the early is cool.
I think we need some TikTokers doing it for us, Simone, not us.
Right.
Maybe a dream, really value sleep. So I think there's it's a good point around. Because it's cool, stay up. I mean, they have a tendency to stay up later. That's what it's a bit embarrassing to go to bed. Like it's a bit childlike almost. It becomes that sort of a cultural thing. Anything else to add around, like in terms of teens? Because I wanted to get on. What was that?
Did you want us to cover sleep disorders in teens?
Yes.
So
yes.
medical type things.
Yeah. And then I wanted to get on to just the other thing after that. I want to just get onto resources, like and also just the steps. So when do you seek help? Like, how do you know when to seek help? But yeah, teens, sleep disorders in teens.
So obviously obstructive sleep apnea is not specific just to childhood, although the stage of enlargement of tonsils and adenoids is usually between around 2 and 8, but lots of other things can cause obstructive sleep apnea. And, if teenagers have a very sort of narrow face or a jaw which is a smaller jaw or set back a little bit, there are anatomical reasons why obstructive sleep apnea can be a problem in teenage years as well, or just really bad hay fever can do it. So always be on the lookout for symptoms of snoring. And I mean, it's harder to watch your teenagers sleep. So, just be aware if the mood is slightly different, or it's even harder than previously to get them up in the morning, that it may be something going on in sleep that may be worth creeping in and having a look at. So obstructive sleep apnea can happen, so can restless legs and periodic limb movement disorder. And then there's this group of extra sleepy teens, some of whom will have narcolepsy. So this is a time where, very uncommon, but I, as a sleep physician, see a bit of this. Actually, I feel like I've seen more of this since the pandemic than I saw before. Teenagers that are starting to sleep too much. So not just sleeping, 10 or 11 hours overnight, but then actually sleeping into the day, 12, 13, 14 hours, or coming back and sleeping 3 or 4 hours after school. That is not normal, and it may just reflect insufficient sleep at night if they've been up longer than parents realise, or that something's been waking them up from sleep. But if that is truly all sleep, that needs referral and investigation. And, there's a group of what we call hypersomnia disorders, of which narcolepsy is one of them. And then there's a whole nother bunch called idiopathic hypersomnia, which they're often really very hard to wake up in the morning. And I mean, 10, 12 alarm clocks don't wake them up type level of sleep inertia. Those ones really should come to a sleep physician, because they need sophisticated sleep studies, which are more than just the average overnight sleep study. They need other tests to figure out what's going on.
I don't know if people know when, like, because it's tricky, isn't it, around sort of mood disorders? Are they just a grumpy teenager? What point at which do you think people should seek the first instance a chat with their GP and seek referral?
Yeah, I think it's when things go beyond the sleep time and the night time, and it's really affecting the child's functioning. So the sort of things we're talking about, if they're no longer enjoying things they used to enjoy, if they're not seeking out their friends and enjoying this, that time with their friends and doing things, if they're not eating as well as they used to eat, if their schoolwork is, going off, their marks are going down, whereas formerly they used to, get a certain mark, all those sort of things that are indicating their function, things that are, are dropping off and their functioning's going off, that could be a sign of depression. Anxiety is, also related to issues with getting to sleep, and probably a lot of people will know the classic thing with anxiety is can be fright or flight or fight. So you sort of freeze, so they can be aggressive and coming back at you, or they can be running off from situations, or they can just freeze around situations. I think that's usually a little bit easier to work out because they hopefully are voicing that they're worried or anxious about stuff. And particularly when they get to high school, it can be the extra academic load that they start to feel worried about that, or kids with autism or ADHD, for example, can have problems maybe with peer relationships that get more complex when you get into the teenage years. So I think asking about that, and for younger kids, I often did a worry box where they wrote down their worries or drew their worries and put them into the box for the night to try and put them away. And then you could open it up in the morning and on the weekend. And sometimes you would just see recurrent patterns of things that kids were worrying about. And then you could start to, move towards solutions for that.
Anything else to add, Mandie? Before we ask people questions?
No, I think we sort of touched on most of the teenage concerns that crop up, and highlighted anxiety and depression as something to, red flags to look out for. I think
that's really helpful. I think I would like to, for the remaining sort of 10 minutes or so, if there's any other questions while we talk about, I'm going to just ask you to, I'm going to put a little slide up again. Let me just share my screen to be, that's not going very well for me. That's the one I wanted to have this up there because I wanted to ask you both around where, while people are putting in questions in the Q&A, where to get specific resources and extra support.
So I can talk to this one, then hand over to you, Mandie, because this is really bringing together 2 decades of our sleep research at the Murdoch Children's Research Institute in Melbourne, and that's a lot of our trials that we've run around behavioural sleep problems in babies, in typically developing kids with autism and kids with ADHD. So if you go onto our website, Sleep with Kip, and Kip's that little purple pillow there, you can actually do a sleep quiz, which is sort of replacing the questions we might ask in a clinical consult about the sorts of issues that your child might be having. And then out of that will come what looks like they're having issues with this or that, and you can go to PDFs of the sleep strategies to work out how, what might help with your kid getting to sleep or getting back to sleep if they're waking overnight or waking up before 6 a.m. to start the day, which we didn't talk so much about tonight, but there's information about that. We've also done a book for each sleep strategy, and it's a fun, engaging book to read, and they're ready for kids aged 2 to 10, the books, and parents can read them. So there's one about that bedtime pass method, there's one about the checking method, there's one about visual imagery and relaxation on the beach. We've also got podcasts, and they go from babies through to teenagers, and for kids with ADHD or autism. So a lot of our resources are on that Sleep with Kip website. And the other place I would recommend parents go is the federal government funded Raising Children Network website, which also has a lot of information about sleep, again from babies through to teenage years.
Absolutely. And I think they're fabulous resources. I'm often referring people, even in my clinical world and in the Sleep Health Foundation world, to the resources you have at the Murdoch Children's Research Institute and Children's Hospital. And there's also the, our Sleep Health Foundation. I'm not sure why this is not clicking on.
The next one.
Yeah, the next one is just there. So if anyone wanted to have a look at our website as well, it's just a QR code there. We have about 100 different fact sheets on a range of topics. But I also just wanted to, just keep that up there while Melanie's put a question in, which I thought was a good one. Can you please comment on children who wake in the night with pains in the legs? Is this growing pains? Are growing pains a real thing?
I can do that if you like. So yes, And that's actually really interesting. And I should have probably mentioned this before, but there is a link between growing pains and restless legs and periodic limb movement disorder. And the link is through iron deficiency. And so if children are waking with leg pain in the night, then it is important to get the GP to take a history about diet and eating red meat or sufficient iron in other sources in the diet, as well as potentially checking a ferritin or iron level in the blood, and potentially giving some supplementation if needed. If that's not needed, I mean, it's still possible to have growing pains, and sometimes they just need a little bit of a rub on the legs, and other times they do need some Panadol or some Nurofen, which it usually comes, growing pains are usually in spurts, like they go for a few weeks and then it settles down again, and then they come back with the next growth spurt. But yeah, it's just important to know that they can be associated with restless legs and limb movement disorder. So to have a check on that.
And they tend to be around the shins mostly, don't they, Mandie?
Yeah,
and tend to be both legs. I think if it was just pain in one leg that kept going, you might go to your GP to get that checked out. But certainly, you know, if it's definitely real, and particularly if it's in both legs and the shins, that's really common.
Yeah.
Right. Any other questions from anyone? I think it's been really thorough. I think we've actually, covered a range of sleeping issues, sleep disorders, when to know, when to be concerned. There's a couple other things coming in. Oh, just some thank yous, which is nice. Thank yous. So I feel like that's probably a wrap for tonight. Unless there's anything else to add from you two that you thought, I didn't say that, I wish I'd commented on something else, or anything else that springs to mind before we close off?
At the risk of everyone needing to get off and do other things, I just think bedwetting is another issue we didn't really talk about in primary school age kids, but certainly on the Raising Children Network website and on the Royal Children's Hospital website, there's lots of the kids' health information. There's lots of stuff about bedwetting, when to get the pad and alarm to treatment, when not to. So if that's a concern, I think there's good resources out there for parents to read.
I guess the only other point on that is that bedwetting can be a symptom of obstructive sleep apnea as well.
Yeah.
Oh, I didn't know that.
Yeah.
There you go. Yeah. Okay. Well, I'm really, really, really grateful to you both. I think it's a fabulous resource for people to be able to have access to such great, renowned experts and local Australian experts. So really, really grateful for your time. And yeah, I think we'll finish off, and I thank you very much to the audience who have come live and those of you watching it later. Check out the Murdoch Children's Research Institute, fantastic amount of resources, and the Sleep Health Foundation as well. So thank you, and sleep well, and just don't put up with poor sleep. There's lots of resources out there. We certainly know a lot more about sleep than we used to. And make sure you tap into the resources and get the support you need. But thanks both. Thank you so much. Thanks everyone. Good night.
Thank
Bye-bye.
you.
Good night.